Is Dr. Sandeep Hedgire, and he's going to be talking about high-risk plaque assessment on CT. Over to you, Sandeep.
Thank you, Rishita. While we are waiting for the slides to show up, I just wanted to thank the moderators here. Thank you, IACI, for this opportunity, and thank you for the invitation. As Mona mentioned, this is the first time we're having a joint session with SCCT, so looking forward to more collaboration from the Indian audience. Additionally, SCCT has a directory of sites that patients can get their coronary CT angiograms. So if you are a site that is doing coronary CT angiogram, please consider adding the name of your site on that worldwide site directory. Thank you. Looks great. Okay. Yeah. But first, I would like to begin by a poll. So there are 4 images shown on the screen, A, B, C, and D. How many people think A is high-risk plaque? Please raise your hand. Nobody? How many think B is high-risk plaque? Raise your hands. A couple. How many think C is high-risk plaque? Okay. How many think D is high-risk plaque? Okay. We'll come back to these poll, but keep your answer in mind. So our objectives in the next couple of minutes is simply to understand what is high-risk plaque, what is the significance of high-risk plaque, how do you review, pick up these findings, and how do you report them in your reporting, and what difference it makes to the patient overall if you say there is high-risk plaque on the coronary CT. Before we get started, I wanted to emphasize certain suggestions from myself on how do we look at these images. When we took coronary CT, when you open a case, it is really important to get the windowing right. The traditional lung as well as soft tissue windows are generally not very good for assessment of coronary CT. You need a window that will allow you to separate the contrast-filled coronary arteries and distinguish them from the calcified plaque. So what is a good starting point? A window width and level of 800-300 combination is a good starting point, but really you should really adjust this based on the patient's image quality, based on the amount of plaque there is. So as you can see on these images, depending on how you window, your interpretation is going to change. Next, I want to emphasize that when you are looking at high-risk plaque, do not look at a large field of view image. Please make sure you really zoom in on the image and do a multiplanar imaging review of the coronary plaque to assess whether or not there is high-risk plaque present, like in this situation. There are 4 high-risk plaque features that I will be talking about. These are low-density plaque, positive remodeling, spotty calcium, and napkin ring sign. Let's begin with the low-density plaque. So low-density plaque is a plaque that has an attenuation value of less than 30 Hounsfield units. You calculate that attenuation by drawing at least 3 random regions of interest. And then here are some examples of how a low-density plaque. So look, here is an example of a proximal right coronary artery low-density plaque. When you draw these ROIs, make sure they do not include the lumen of the coronary artery. If you include the lumen, the value is going to be high. Also make sure do not include the adjacent pericoronary fat. If you do that, the value is going to be low. So be cognizant of that. Literature tells us that non-calcified low-density plaque is more frequent in acute coronary syndrome in comparison with patients who have stable angina. More recently, data from SCCT heart trial has shown 2 important observations. First, low-density plaque is able to predict myocardial infarct, and second, a low-density plaque less than 4% is better, and more than 4% is much worse in patients who had fatal myocardial infarctions. Let's talk about the positive remodeling. This goes back to 1953 when Crawford and Levine wrote in a journal that atheromatous plaques do not project in the lumen but lie in the depression in the media which may bulge outward. I have taken the liberty to modify that sentence to my liking and I have made it as a modified atheromatous plaque do not project in the lumen at first, but lie in the depression of the media, which may bulge outwards before leading to significant luminal stenosis. The roots of the positive remodeling also lie in the Glugau phenomenon. So this is a remarkable study from Chicago where they analyzed human hearts and looked at whether the vessel dilate with presence of plaque. And the Glugau study tells us that as the plaque develops, the area of the coronary artery also enlarges. That increase in diameter is also increased in the cross-sectional area. And then we have to note the conclusion of this study, which was coronary arteries enlarge in relation to the plaque area, and functionally important lumen stenosis may be delayed. This is really important because your patient may have high-risk plaque, but yet may not have an obstructive severe luminal narrowing. So keep that in mind. So how do we calculate positive remodeling? We need multiplanar images, and on multiplanar images, we simply measure either the diameter or the area of the segment of the vessel that has enlarged in size. So here is an example of proximal NAD plaque where I have measured the ratio of the enlarged segment of the vessel and compared that to the normal segment of the vessel. You need a ratio of at least 1.1 to make it a reliable predictor for high-risk plaque feature. This is some of the data from the literature that tells that plaque area and positive remodeling were found to be more associated with culprit lesions in patients with acute coronary syndrome. It's a marker of surrogate plaque vulnerability in this population, and then it correlates very well with the other high-risk plaque feature which we just looked at, which is low density plaque. Another thing that we are seeing in the clinical practice is sometimes these patients, even though they are on statin and optimize their medical therapy, they do progress. Here is an example of a patient who came to us, I think, in 2019, and 3 years later, please note the ratio here, which was 1.2. 3 years later, the ratio has progressed further and now is 1.5. So high-risk plaque feature like positive remodeling is much more common in LAD, and it is the most frequent high-risk plaque feature in comparison with other features that we are talking about today. Let's move on to the napkin ring sign. So napkin ring sign is defined as a peripheral higher attenuation of non-calcified portion of the coronary plaque. And it is very easy to get this confused with the low density plaque. So I have put them side by side, and on the green boxes on your right, you will identify that there is a very subtle high density rim along the outer edge of the plaque. And this is what fibrous component of the plaque is, and which is from going outward to inward, it's fibrous component followed by low density plaque followed by lumen is what you're saying. And these correlate very well with the histopathological images. This is an example from the literature where you can appreciate the high-risk plaque feature in terms of height, rim of high density in figure B, and then what high density there is represented is actually a fibrous tissue within the plaque itself. Similar to the other two plaque features I showed, napkin ring sign is also an independent predictor of future acute coronary syndrome. The sensitivity is exceptional specificity is exceptional, but sensitivity is very low in detection in patients who have these findings. The last high-risk plaque feature is spotty calcium. As the name implies, it's a spot of the calcium. But you will notice that there is a little caliper placed at the bottom right image there, and that is because you can measure the diameter of this calcium only, and the diameter needs to be less than 3 millimeter in size to qualify as a high-risk plaque feature. Particularly if the spotty calcium is less than 1 millimeter, they are much more likely to be associated with thin cap fibroatheromas, which are common culprit in acute coronary syndrome. Literature also tells us that these findings correlate very well across all the imaging modalities. And here is some data from the pathology literature from Renu Weidmaring's group, and it tells us that while we talk about spotty calcium, it tells us that little bit of calcium is bad, We also know that too much calcium is also bad. So here is a breakdown of how much calcium is really bad. So as my parents told me while I used to eat a lot of sweets growing up, they used to say, eat everything but eat in moderation. So too much of the either extreme is bad. So too little calcium is bad because it implies that this plaque is vulnerable, and then too much calcium is also bad on the other end. But what if you are reading a case and you identify more than one high-risk plaque feature? So there is incremental benefit to identifying more than one feature. The more features present, the bad it is. So it's not only yes or no for high-risk plaque, it is also how many high-risk plaque features are present. In terms of reporting, you need to be aware that these reporting guidelines keep changing on us, like particularly the SCCT recommended that we use CAT-RAT system. So here is a breakdown of how it was in CAT-RAT's original CAT-RATs and how it changed over CAT-RAT's 2.0. So with regards to the high-risk plaque feature, previous guidelines said we should use the term V for vulnerability. We have changed that and moved away from that term. Now we are using HRP, standing for high-risk plaque. But you need 2 or more high-risk plaque features to give that designation of HRP. So in summary, there are 4 high-risk plaque features: low attenuation plaque, napkin ring sign, positive remodeling, and spotty calcium. It's not only presence of these plaques, but also the segments involved in these plaques, as well as whether one or more plaques are present. That is the key to determine whether they are a marker of vulnerability and whether these patients will develop ACS down the line. Here's a little bit of summary from the literature that tells us the studies, and from the table you can tell that positive remodeling is the plaque feature that is extensively studied in the literature. I have not forgotten about the poll that I showed earlier. So coming back to the poll, the center 2 images are the high-risk plaque feature. The second image shows you positive remodeling. The third image shows you a spotty calcium. The first image shows you just a calcified plaque, and the last image is a large right coronary artery aneurysm. With that, I will end here. I would like to thank my team at Mass General Hospital. It takes a lot to run a large cardiovascular center program like ours, so I really appreciate their efforts. Thank you so much. I'll happily take your questions either now or after the session.
It was a half an hour talk. You finished in 15 minutes. You have 15 minutes for
Excellent.
Q&A, so we have a lot of time.
My general philosophy is never exceed the time allotted to you and always leave time for questions. So.
But that's a lot of time. So are there any questions from the audience? And if Vineet is around, we can actually do Ritu's question because we really have time. So, and thank you for that.
No problem. No, he's not here.
Sorry? No. So, I mean, I think we can talk about high-risk plaque a little more. No, I think one of the issues with high-risk plaques is the understanding, but we don't have a good study to show that, is that these are the ones that are supposed to rupture and perhaps cause a sudden cardiac death event. Are you aware of a reasonably long-term study that has shown an increased incidence of acute coronary syndromes with increased mortality in a population of high-risk plaques, which, depending on the type of high-risk plaque. So yes, if you have high-risk plaques versus no high-risk plaque, that's a no-brainer. But within that, whether it's a spotty calcium, whether it's a napkin ring, does it make a difference? Versus the extent of atherosclerotic disease, number of plaques, does that correlate with the incidence of mortality or events, acute events?
I think that's a great question. So I will answer some, and looks like Vineet also wants to say something about this question.
I think Promise there is a sub-study in Promise that showed it.
Yeah.
And also there are more and more studies which they don't look at traditional 4 kind of types of high-risk features. They look at more at non-calcified plaque volume, and they have shown that those are associated.
So a couple of things. I think really practical question and really practical real life scenario is that not everybody gets multiple serial coronary CTs to assess how the plaque is progressing over a period of time. So there is not a large multi-center study that has looked at that. And also, when we do coronary CT and if there is no plaque in coronary CT, the warranty period for a negative coronary CT is generally considered around 2 years, and at least in the United States.
I thought
So
it was 5. But you said
it's 2. So we in the United States we don't repeat a coronary CT. I think that's one of the reasons. And many of these patients, when they get the diagnosis of no plaque, no stenosis, then they don't get put on statin therapy, and then they come back many years later with acute chest pain in the emergency department, and that's why we need a study that will evaluate the temporal changes in the plaque composition and high-risk plaques.
so we've seen anecdotally the other way around. That is, we've seen high-risk plaques, people on high-dose statins, coming back 2 or 3 years later, and the plaques having calcified, so and reduced in size. Okay, Ritu, your question.
We typically don't, and it depends on the temporal resolution of the scanner. I think a little bit of motion is tolerated, and yeah, usually it doesn't require. If there is motion, yes, yes. So again, it depends. Like sometimes we end up repeating. If images are so terrible, we repeat them, but we never. I think that's too much to do for a calcium score CT.
It is a known problem with coronary calcium score, particularly if you have motion, as you said. The right coronary artery is the artery that moves a lot throughout the cardiac cycle, so you can overestimate the degree of calcium score. There are centers in the world who do retrospectively gated calcium scores, believe it or not, but I think that's a little excessive, and the radiation dose tends to be very high just for a calcium score.
So correct me if I'm wrong, just taking that argument on, if now we're talking of eyeballing mild, moderate, severe without measuring on CTs, then how does it matter? Whether it's 50 or 60 or 70 or whatever it is, I mean, so then the heart rate and the technique matters less, because we're seeing now that just by eyeballing you're able to pretty much risk stratify people. Then what is the point being so obsessive about technique? I mean, your take on this.
Yeah, actually, most important numbers that matter are 0 and non-zero. So if it is 20 or 25, it hardly matters. So
no, so then I have a counter argument, right?
Yeah.
So I did a lot of friends and family screening about 5 years ago, and I got all their triglycerides and LDLs done. A lot of guchu vegetarian giants, right? Eating otherwise sensible food will never get an LDL below 120. But their calcium score is 30 or 40. Their ASCVD risk factor is about 7.5%. What do? You put them on statins, you don't put them on statins.
yeah, I think guidelines say you should consider statin.
Yeah, that is the whole role
Yeah.
of calcium score.
Yeah.
The point of the calcium score is it doesn't matter what's the heart rate and all, because you want to know is it 0 or not.
Yeah.
It's in the low risk variety. So if you have an absolute 0 calcium score, it's only to improve your risk stratification of a patient. It's really not for checking on what is the...
Yeah, but 5 is a...
Even 5, you basically...
You can't put a 5 and an LDL of 120 on statins.
No, because the point is if you have 5 calcium, that means there's a lot more non-calcified plaque also inherently inside it. Are you going to never bring a CTA?
Rajesh.
You have uncertainty.
Sir.
When you're talking about the calcium score, we are looking only at the Augustan score, the number. And what about the other information which is we are getting from the calcium scoring program, like the density factor and the volume thing? So does it have an independent risk factors which generally we don't give too much significance? But I think there are literature says that the density factor especially will be one of the other important things. But I don't know how much clinically it is people are applying it.
Yeah, I think like most data is based on Agatston, and actually people have looked at many different things, but none of them have added any more value. I mean, the people say it's very high density plaque that is actually protective, but because more calcium means more chronic stable plaque. Yeah, but most important number remains the total Agatston score.
You know, it's even more complicated, and I'll just come to you. So athletes have high calcium scores, but do they have disease? No. Do you put them on statins? Why? Because they were otherwise fit to be with. It's not easy. All I'm trying to say is there is a movement that says calcium score can risk stratify. But the reason why the USPSTF doesn't put it in the guidelines is even today, we do not know that by using calcium score as a method of risk stratification, are you able to change the eventual outcomes at the end of 20 years? There are 2 RCTs ongoing, one in France and one somewhere else, which will yield results at the end of 10 years. They started about 5 or 10 years ago. Then we will know perhaps for sure whether it's worth it or not. It's a good thing to do in a select number of patients, but there are issues as well. Priya, go ahead, sorry.
I just wanted to say the same thing, that gating actually shouldn't matter because we are doing the same, calcium scoring on the non-gated ordinary NCCT chest also, and what we found was, yes, we did miss some calcium, so the difference was just 5 to 10%, and it does not make a difference whether it is 250 or 300 score.
Yes.
Yeah.
So what is important, it should be 0
Yes.
or non-zero, then it doesn't matter.
Yeah.
Unless, yes, you want to see what is the underlying vessel and you are going to do a coronary CT angio and you don't know whether you will be able to see the vessel underneath that. In that case, probably a gating would help, but otherwise there is no need. Second thing I wanted to ask you was, are you doing quantitative CT plaque analysis?
Clinically, not yet,
no, yeah, okay.
but we are entering in a phase where we are assessing the possibility of providing that kind of clinical service, hopefully in the next 1 year.
So you mean you will be doing CTs for the pure purpose of plaque evaluation? Because that's not recommended as of now.
Right. It will be, it's not solely for the purpose of plaque evaluation, but also in symptomatic population, as the current guidelines say, that you do a CT, but you also, along with your CADAS 2.0 style report, where you grade the stenosis, grade the plaque, and then in addition to that, you provide a quantitative metric saying that this is the total percentage of plaque volume, this is the breakdown, this is how much non-calcified plaque there is, and like these are.
So any data wherein you could, correlate the quantification of the plaque with the MACE, I mean, that would justify doing plaque, say follow-up also at least.
Dr. Johnson in his talk mentioned that the plaque volume is the new trend in our field. So I think in the next couple of years you will see more and more people focusing on plaque volume quantification and slowly moving away from CTFR.
And how is the scenario regarding doing MR for the plaque follow-up? So you have found a bad plaque, an ulcerated plaque, or very real bad plaque, and you said the patient is put on statin. So any scenario wherein you are doing MRs for follow-up, or?
We currently are not doing
Okay.
MRs as a follow-up test following a coronary
So,
CT.
yeah, my understanding is research on MR for plaque analysis has pretty much, has pretty much stalled.
No, sir, because the focus suddenly is a lot on plaque. So that is why I was asking them if they have started some, pioneering work or something.
Following the
so
research,
it
it's
will come out.
stalled. There is nothing. It's all CT based. All the MR stuff is gone, and then you also have a huge movement on CIMT.
Doing CT for just plaque is
No,
not
I
indicated.
agree.
So that's why I was saying probably MR.
Yeah. You have a question. Go ahead.
Yeah.
So how many of you are following the cataracts 2.0 in your reporting? I am, but generally I'm asking.
So
Let's get a raise of hands if you're following CADAS 2.0 in your report.
So how many of you, that's good number, I'm happy that we're doing that.
So many of you, have you any time come across that you report a HRP and plaque burden? Like we have a automated, semi-automated kind of software. We try to report a plaque burden. So quantitative, should we do it? Should we not? And does it make a difference in a real practice till now? Have you come across any case like that?
So there is ongoing data in the literature that says that plaque volume quantification will be coming soon down the pipeline. It's not made its way yet in the ACC or AHI guidelines, but that might change in the next couple of years, is what I would say. With regards to whether or not you should say this is the overall plaque burden, I think if you have the ability, the resources to do it for every single case, I mean, good for you. We do about 60 coronary CTs in a day with 2 people managing the scanner, and it's just not feasible in our system.
Thank you.
So, go ahead.
Yes, I showed some of that data on my slides. So basically, not only presence of a high-risk plaque feature is important, but the more number of high-risk plaque features that are present, the more it is related to development and acute coronary syndrome down the line. So that's a great question. So the Candidates 2.0 guideline says that you need at least 2 high-risk plaque features to use the term HRP. So what do you do if you only find one? So you cannot use HRP if you just find one. But what I do is if I see one and it's only that one particular feature, like say I see napkin ring sign, I would put it in my impression and say, although this does not meet the criteria to be labeled as HRP, there is presence of napkin ring sign. And you'll find that in the, not only the body but also in the impression field of it.
All right, so we have now about 2 minutes 55 seconds.
Yeah, so you can quantify it. Like with software, you can segment the right ventricle both in systole and diastole, and you can get EF and volume and everything. Yes. Yes, you can do that.
Vineet, quick question. Have you ever encountered a downstream problem with a high calcium score in an asymptomatic person, especially if they're doctors or doctors' relatives, where they start freaking out and then getting an angio done and a dobutamine stress done, etc., not understanding. Yeah, that's the other problem. You're not supposed to have that happen, but it happens all the time, and that is a negative thing of calcium score that people don't talk about. So we do that. Great, thank you so much, Sandeep and Vineet. Great, and that was a good Q&A session. We move on to the next lecture.
Great, thank you.